dependence versus severe use disorder. So the question as it came in says, can you code dependence, say for alcohol, if the provider states alcohol use disorder severe, since it does not say dependence, but the provider said he's going by the DSM-V, and it is dependence, and they are not going to change the wording. Okay, so that was the first question, and this is actually a two-parter, because the second question that we received says, can someone explain the smoking dependence codes? Does the physician have to document that a patient is dependent in order to use these codes? Some of you are probably going, okay, the first one's on alcohol, the second one's on smoking. Why are you combining these two? Well, they're both all about dependence and how we define dependence in order to be able to code for the services. The first question actually was very intriguing to me because I have a background working in mental health services. Not as a patient, let me clarify that, but actually working with the mental health providers. And I do actually have a copy of the DSM-IV and the DSM-V if you've never heard of either of these two manuals. We are now in DSM-V, just like we went to ICD-10, right? DSM-IV was the previous version. DSM stands for Diagnostic and Statistical Manual, and it's of mental and behavioral disorders. So this is actually what the social workers, the psychologists, the psychiatrists use in determining which condition a patient has, especially when you're trying to make a determination between things like, you know, defiant disorder versus intermittent explosive disorder, or alcohol abuse versus alcohol dependence. There are certain criteria that a patient has to meet to qualify for the diagnosis. And I found this interesting that for that first one on alcohol use, you know, they said, well, as a coder, we expect to see alcohol dependence. Most providers don't call it alcohol dependence, right? They document it as alcohol abuse, and then they document the criteria that the patient meets. And like this provider had said, well, I'm going by the DSM-V requirements. So what I did in the answer sheet and what I'm going to talk through is if you're familiar with DSM-V, and especially if you have a provider that says, I document based on the DSM criteria, I am not going to write alcohol dependence. Okay, that's fine. That's that provider's choice. But you need to know that they're using the DSM so that you know what to use in reviewing the documentation to see if it meets the criteria for dependence. And this is kind of how the DSM works. It's actually really simple, and it's kind of fun reading. It's even more fun to try to diagnose yourself and your coworkers. Trust me, I've done it, right? Yes, I do know what my own DSM code is. It's all right. But the DSM-V lists the symptoms for alcohol use disorder, for example. They say, here are the symptoms for alcohol use disorder, and in order to be qualified as severe, which equates to dependence, the patient has to have at least 6 of the following symptoms. So the symptoms that they look out here, they say a problematic pattern of alcohol use leading to significant impairment or distress as manifested by at least 2 of the following occurring in a 12-month period. Now to be severe, they have to have 6 of these 11 that are listed under here. So they require more alcohol. You know, alcohol is often taken in larger amounts or over a longer period than they intended. So they drank more than they really planned on drinking. There is persistent desire or unsuccessful efforts to cut down or control alcohol use. There's a great deal of time spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects, including hangovers. Craving or a strong desire or urge to use alcohol. Recurrent alcohol use resulting in failure to fulfill major role obligations at work, school, or home. Continued alcohol use despite having persistent, recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. Important social, occupational, recreational. Do you kind of see a trend here? Right? They're choosing the alcohol over everything else in their life. And to meet the criteria for dependence, they only have to have 6 of these, and there's 11 listed here. So if they're using more than they intended, they're having trouble cutting back, they're suffering more from hangovers and taking longer to recover, and thus missing work, missing out on family obligations, and continuing to use alcohol even though it's causing them to fight with the people around them over the use, they've just met the criteria for being dependent. And that doctor didn't have to say anything more than alcohol use and describe the situation that this patient is facing. I then went on below this to explain the same thing is true for tobacco disorder. I know that's a big one I get a lot of questions about, is how can I say that this patient is dependent on tobacco? your provider probably gave you all the information that you need in that record. And some of that starts as easy as saying, you know, patient's been smoking for 22 years, smokes 2.5 packs a day. Do you think that they plan to smoke for 22 years? If they smoke 2.5 packs a day, they're probably, you know, this is where the doctors oftentimes, what's the word I'm trying to say, identifying that they are using more and more, especially if you look at how much they smoked before, right? They've got to have more to get the same effect. And those are the things that you want to clarify with your provider. You know, are we meeting all of the criteria to report dependence? Because some organizations say you have to use the word dependence, and when I say organization, that provider group, the hospital, whatever entity you work for in coding. Many of them say if they meet the DSM criteria, they qualify for dependence. And if you have a DSM, or if you get a chance to look at the DSM, it's kind of fun, but it shows you not only the category codes, but it links to an ICD-10 code. Now, be aware that DSM is not updated nearly as frequently as ICD is, so you do still have to look at how they cross over, but they do cross over because the provider may assign a DSM category, but what goes on the claim is an ICD-10 code. So when we look at both alcohol dependence and tobacco dependence, it's going to come down to how does your provider document it? Are you expecting them to document dependence? Because they don't have to if they choose not to. But many of them don't know what the criteria are that they have to document unless they are a mental health provider. If you're working with a family practice physician or internal med physician and they don't want to write tobacco dependence, you need to talk to them about, okay, well then here's the criteria that the patient has to meet for me to call it dependence without you writing the word dependence. Because sometimes that'll make a difference in how they document their services. Sometimes they'll go ahead and call it dependence. Sometimes they'll say, that's fine, use it as abuse.
Okay. Good stuff. What website can I go to for review of DSM-IV or 5? Ramil asks.
You actually can't. Unfortunately, the DSM-IV and the DSM-V are not available online. They're also not available in electronic form that I've been able to find yet. But they are published by the American Psychiatric Association, or the APA. You can get a copy of it through Amazon. It's not super expensive. It's a thick book. It's about this thick. And it's a smaller book. It's not as big as like your CPT manual or your ICD manual. It's not an 8.5 by 11. It's a smaller. It's like a, I think of it as like my planner size, right? My junior planner. But it's a very, very thick manual. And it's, quite frankly, it's an interesting read. I never read it until I started working in mental health, and then I'm like, wow, I didn't know they did all this stuff. And my coworkers and I at the time started diagnosing one another. We're like, hey, this is you, that sort of thing.